Okay, so we'll get started. Everyone's got the handouts, which is awesome. You can use the beanbag if you want. We have more chairs available if we want to grab you a chair. We can. This. The beanbag's pretty good. Okay, so the reason why we need to think about myopia control is it's an opportunity to look into the future. And we do this all of the time with things like glaucoma management, for example. We look into the future and think if we don't treat this, then this might happen for this patient. We need to think about myopia the same way. And hopefully you already have a bit of an understanding about how myopia is not just a refractive correction. It's not just a condition that we correct with spectacles or contact lenses. That myopia is actually a disease, and every part millimetre increase in axial length means a greater risk of disease. So this is why we need to be really focused on the future. This is a quote from a Russian astrophysicist, so not an optometrist at all, but this is our opportunity to really think about what the lifelong risk might be for our patient and actually modifying that. The reason this is important is that we know that there's a boom of myopia occurring around the world, and we know that it's not just particular ethnicities who are having this problem, that it's across ethnicities and it's moving too quickly to just be genetics. We also know that if we can apply myopia control treatment of 33% efficacy, a reduction in axial elongation of 33%, that means across a population, analysis was done by Noel Brennan, that means 73% less high myopia. We already know we've got this arbitrary line of physiological myopia and pathological is more than 5 or 6 doctors. However, we're going to talk a little bit later on about how even lower levels of myopia can be termed pathological. There may be no such thing as safe myopia. And if we can apply a myopia control strategy which has an efficacy of 50%, this might mean a reduction of high myopia across a population of 90%, and that's a pretty big deal. We're going to talk a little bit now about how there's no such thing as physiological myopia. Has anyone heard of this paper by Ian Flitcroft at all? You've got it in there so you can download it. It's my most favourite myopia paper ever, and that sounds really nerdy, but you know, I can say that to you guys. It's my most favourite myopia paper. It's about 39 pages long, so if you're ever struggling to get to sleep, have a read of that. It's got numerous parts to it. No, it's an awesome paper and it's definitely something worth looking at. I want to tell you more about that paper, but I want to tell you about it through the story of Sarah and Abby. So Sarah and Abby are actual patients in the practice that I've extended and used some artistic license to tell you about what might happen to them over a lifetime. So Sarah and Abby, both actual true story, at age 7 were right and left -1. Now -1's a really tricky correction to get a kid to wear, because if you're 7 and you're -1, you got no problems. Everything is perfectly fine. But we know that an undercorrected myope is at risk of further progression. And so by age 8, as we might expect, they both progressed to right and left -2. Now this is serious business, this is when we start talking about myopia control. Because if you're already -2 at age 8, you've got a lifetime of likelihood of high myopia ahead of you. So the time to start myopia control treatment is right now, because progression decreases with age. The longer you leave it, the more you miss that boat to do something really significant for this patient's overall final level of myopia. And so we know that if these kids are 8 years of age here, that they're likely to still progress. So a child of Asian ethnicity by about a diopter a year, and child of Caucasian ethnicity by about 0.8 diopters. So we want to do something about it. We can't assume that it's going to continue on that same trajectory the whole time. We know it slows down, but this is really an indication that the time to start treating is right now. Now we know there are cases of people who are over 18, adults with progressive myopia. I didn't become myopic until I was 19, and I progressed for a year and then I stopped. So I started optometry with perfect vision and ended with dodgy vision, a little bit ironic. But as a whole population, we've got some old data. We need to get better data about adult progression of short-sightedness. We still have those patients who progress, but generally the sooner we do something, the better. So back to Sarah and Abby. Sarah's mum wears glasses, she's -5, she doesn't think it's a big deal to be -5, nothing bad has happened to her eyeballs in terms of pathology, and she said that her husband, Sarah's father, was very dubious about her daughter wearing contact lenses. Obviously we'd had a discussion about contact lenses when we were talking about myopia control. So Sarah went to glasses. Now we know that single vision glasses, I'm sure you guys are aware already that single vision glasses do big fat 0 for myopia control. And Sarah ended up being lost to follow up. So for the purpose of this discussion, we're going to assume that Sarah's in single vision glasses, so she's our control, and she's been lost to follow up for a period of time. Abby's got parents who wear contact lenses. His mother wears contacts and his father wears contacts as well. So they were very happy about the idea of their son wearing contact lenses. And so Abby was fit with Ortho K. So we're going to imagine Sarah and Abby forward now over 5, 10 and 40 years and have a look at their lifelong risk of eye disease associated with myopia by their level of myopia. So firstly, let me just show you something. I spent a lot of time on Google Images trying to get kids that matched. How good is that? And just each time I switch a slide, I just want you to take a moment to appreciate how much time I spent on Google Images trying to get that right. Okay, so yeah, pretty good job, Kate. Nice one. Okay, so here's Sarah in her glasses and Abby in his contact lenses, or no contact lenses because it's during the day. He's wearing Ortho K. Now I've applied that average progression. That graph I showed you before was the average progression of control groups in myopia studies, so kids in single vision spectacles. And so what happens with Sarah over this period of time is that she's likely to progress, and Abby will progress by a lower amount because he's wearing Ortho K. So what we've got here, what we're going to talk about is the risk of microbial keratitis, because that's the first and foremost thing that's of concern in our mind when we're fitting a kid with contact lenses, is this risk of MK. And so we're going to, but there is a risk of MK even if you're wearing glasses. So I want to compare the risk of Sarah wearing glasses with MK to Abby wearing contact lenses. Now for 5 years, over this period of time, Sarah's been wearing glasses. The risk of microbial keratitis is 0.07%. That's the risk of her having an MK at any point. Abby's risk of MK is 10 times higher, but still pretty small, isn't it? That's a cumulative risk over 5 years of them wearing that type of correction. But over this period of time, Sarah's progressed to -5, and Abby's progressed by about half of that rate, because we know from meta-analyses that Ortho K slows progression by around 45-50%. So he's only -350. Now let's imagine them forward another 5 years. Google Images triumph. Do you see that? Pretty good. So Sarah's still in her glasses. Abby's been wearing Ortho K contact lenses for 10 years now. Sarah's risk of having one episode of microbial keratitis over that period of time, over that 10 years, is 0.14%. And Abby's is 1.4% over 10 years. So it's still 10 times higher, but still very low odds that he will have had an infection at all. Sarah's progressed to -750. And that is using that average progression from that previous. You're having problems getting out. It's just an obstacle course. That average amount of progression that I showed you in those graphs earlier, and Abby's progressed to -475. So he's still a decent myope, and we might have expected that because he was -2 at age 8, but he's progressed significantly. We've got more chairs for people up the back if you want to see. Or there's some more chairs that we can, you're okay? Okay, now we're going to imagine them forward another 40 years. Now, Sarah and Abby both went to university. They both headed out into the world. They both did very computery sort of jobs, which we're not going to factor necessarily into their rate of progression. We're going to say that they didn't really progress much more from age 18, even though we know that that's sometimes the case. Now, Sarah went and wore soft contact lenses. As soon as she moved out of home, she said, I'm sick of these glasses. I'm going to get fitted with contact lenses. And she's been wearing soft contact lenses for a period of time. And then she had 18 years of her life with no contact lenses, and then 40 years wearing soft contact lenses. Now, Abby wore Ortho K for 25 years, and then he's gone and had refractive surgery. So we're not going to worry about the type or the infection rate with that, because the infection rate with the surgery is obviously much higher than any type of contact lens wear. So I'll just factor that out of the equation. But if you have a look at that here, Sarah's been wearing soft contact lenses, so we're imagining her into the future. 40 years of a daily disposable soft contact lens. We might grab some more chairs, possibly. There's some out the back as well. 40 years of wearing daily disposable soft contact lenses, and Abby's had 33 years of no contact lenses, but he wore Ortho K for 25 years in arguably a more risky modality, so more risky type of contact lens wear. Now, if we imagine it forward 40 years, we might imagine that Sarah's wearing some blue blocking, UV blocking, auto-accommodating, toric multifocal amazing lens with virtual reality input that doesn't exist yet. Imagine what lenses you guys will be fitting in 40 years. That's what she's wearing. But Abby's worn these lenses for this period of time. Okay, so let's have a look at what their risk of microbial keratitis is over their lifetime. So the risk of Sarah having one case of microbial keratitis in her lifetime, wearing 40 years of daily disposable wear, is 1 in 95. Whereas for Abby, because he's worn a more risky type of Ortho K, and pediatric Ortho K appears to be slightly riskier than adult Ortho K, It's 1 in 51. The studies that have looked at risk of MK have shown minimal incidence of permanent vision loss. So it's hard for us to say no vision loss, but it does indicate that there's minimal risk of permanent vision loss. Now, this is where I want to bring in my most favourite paper ever. So you've got it there, you can download that. And it's a serious corker that talks about risks of pathology with higher levels of myopia. It also talks about how the outdoor time thing might not necessarily be about daylight. It might be more about the dioptric field of view, so looking long distance and having an even field of view across the retina. There's a lot of really good stuff in that paper. But what I want to draw your attention to is the start of the paper, the first 5 pages or so, that make a very convincing case that there's no safe level of myopia. Now, when we have a look at the data from the Flitcroft paper, and you might have seen something like this before, with higher levels of myopia comes higher levels of risk. And the stuff that's really scary is this myopic maculopathy here. We generally think of -6 or more as pathological, but if we have a look at -3 here, which we generally thought -3 is not a big deal, that's physiological. Actually, for someone who's -3, there's nearly a 10-fold, sorry, these are odds ratio, 10-fold increased risk of myopic maculopathy. Now, there's some work around the world now to really characterise what that is. It's not macular degeneration, it's a stretching, tearing sort of a problem at the macula and neovascular membranes. Now, I'm -1, and I think -1 is pretty rad, and I'm going to be pretty happy being -1 until I'm about 50, and then I'm going to need reading glasses, and that's going to suck, but at least it's not going to happen when I'm 40. But I'm wrong to think that -1 is benign. Even with -1, I've got double the risk of cataract, I've got 3 times the risk of retinal detachment, and 2 times the risk of myopic maculopathy compared to somebody who's emmetropic. So I don't mean to make all of the myopes out there feel depressed, but this is really important for our patients and for ourselves as well, that we really think of myopia as a disease, that it's not just about a refractive correction. And then particularly with kids, where we've got an opportunity to modify what their end level of myopia might be, this is something that is important for their lifelong eye health. So ultimately, when we're looking at myopia control with contact lenses, we need to think about what is more concerning for you, the immediate risk of microbial keratitis, which is quite small, versus the definite lifelong risk of things like PSCC cataract, which is not a big deal, that can be fixed, but retinal detachment, macular degeneration, myopic maculopathy, they're very big deals. We need to think, what's the risk now versus what's the risk in future? And that's a bit of a tricky message for you to talk to with parents and with patients. But it's the same sort of message really with glaucoma. We don't know with glaucoma which ones are going to progress and which will be quite stable. So we don't know for sure that a -8 will have a retinal detachment. They may not. There are more people out there in the world who are -4 who've had retinal detachments just because there's more -4s. So in each individual it's going to vary, but we know that when we look at the overall data that there's definitely these risks that are absolutely concurrent with higher levels of myopia. So let's go back to Sarah and Avi, and we know that Avi's worn a riskier type of contact lens wearer and he's worn it in childhood, but we're going to have a look at their risks of myopic pathology. Avi's -475, so still on the border of what we might call pathological myopia, maybe not. Sarah's definitely a decent amount myopic. So the risk of Sarah having 1 retinal detachment in her lifetime is 1 in 7. The risk of Avi having a retinal detachment in his lifetime is 1 in 17. The risk of myopic maculopathy for Avi at this level of myopia is 1 in 24, and for Sarah, 1 in 2. It's pretty scary stuff. So we really do need to think, even at these lower levels of myopia, the difference between someone being -2 and -3 is actually a difference in lifelong eye health risk. So that's the why of myopia control. And hopefully you're all feeling pretty dead cert on that and ready to talk to your patients about that. That's the why. And that's a tricky sell, but think about it similarly to glaucoma. We're describing we need to treat this because this might happen in future, or this might happen in future for the myope. Myopia is not just a refractive correction. Now, I want to compare Avi to his long-lost twin brother, Bavi, who was wearing a myopia control daily disposable lens with a lower efficacy. Because it's highly likely that you may not fit Ortho K when you graduate. You need to be in a practice with a topographer, you probably need to have a mentor who's fitting it as well, even if you've had experience at uni. But there are lots of myopia control lenses becoming available. There's the MySight lens from Cooper Vision, which is under limited release in Australia. And there's some more coming to our shores in the near future. So you might think 33%, oh, that sucks, why should I bother? If I'm not going to fit Ortho K, I can't do myopia control. But I want you to know that you can. Because if we fit Babby with his myopia control daily disposables over his lifetime, he's ended up minus 575 compared to our control, Sarah, who's minus 750. His risk of myopia of microbial keratitis when he's worn daily disposables is 1 in 90. So you can see it's pretty low. He's worn contact lenses a little bit longer than Sarah, who only started in adulthood, but still quite low. His risk of retinal detachment pegs him in the same refractive group as Abby, but his risk of myopic maculopathy is higher. So you might think, no real difference between 475 and 575, but there is in terms of that lifelong risk. So hopefully I've got you all convinced about that myopia control matters. Obviously you're interested or you wouldn't be here. So I've got a bit of bonus material in the presentation there, lifetime risk benefit analysis. And this is a bit small for you to read from here, but you've got it there to look at later. So what I did is some calculations where I looked at the average lifespan of a person, the average lifespan of a correction, so how long they might be myopic, and looked at these incidence rates and created sort of an annualized lifetime risk. And the things that I want to draw your attention to is that, so you can have a look at these in your own time, is that the risk of myopic maculopathy when we get to -7 or greater is 1 in 2. And then have a look up here at our contact lens risks. The most risky way to wear contact lenses is extended wear silicone hydrogels. And if someone wore extended wear silicone hydrogels for their whole life, which you might think, oh, your cornea is going to fall off. Actually, their macula is more likely to fall off if they're over this higher level of myopia. Retinal detachment. So have a look here, this -6. I don't have to tell you -6 is a worry with retinal detachment, but have a look at even the -3, a 1 in 17 risk. And go up here, if someone's wearing pediatric Ortho K, their risk of an MK in their lifetime is 1 in 14. And they wouldn't hold that risk for their whole lifetime because they're not going to stay a kid forever. So this is to really show you that those immediate risks versus the lifetime risks are something that's absolutely worth keeping in mind. So just to pull some of these out, the risk of retinal detachment is 6 times higher than the risk of microbial keratitis in the 3 to 6 diopter myope wearing daily disposables. The risk of myopic maculopathy is equal to 50 years of extended wear silicone hydrogel in someone who's 5 to 7 diopters. So that's pretty sobering stuff, isn't it? Because this is such a far away thing, you know, it's hard to keep in mind, whereas this is an immediate risk. But actually, wow, someone could be really doing nasty things with their contact lenses and have a similar risk of myopic maculopathy. The risk of myopic maculopathy is 3 times higher than the risk of microbial keratitis in a high myope who's wearing pediatric Ortho K. Now, they might not be suitable for Ortho K, so that's a high amount of myopia. But just to demonstrate to you, that level of myopia is what really ups the risk. So the risk of losing lines of best corrected acuity, which is our main concern with microbial keratitis, is very low with both types of modality. Lower levels of myopia obviously make contact lens wear more risky, but those future risks of pathology are really certain. So -3 is sort of where we want to keep people if we can. And then if possible, our next level is -6. So which scares you more? Which scares you more? Microbial keratitis or maculopathy? Maculopathy scares me more. We can manage microbial keratitis. That's something someone's more likely to completely recover from, isn't it, than that? Okay, so myopia control research results. I've got a lot of stuff in the presentation there, but just to show you a summary slide, we know that atropine has good results for myopia control, but there's a rebound effect with higher concentrations. I presume you guys have covered a lot of this. So the low-dose atropine is really where it's at. Normal RGPs and single vision soft lenses have no effect for myopia control, and same with single vision spectacle lenses. So prescribing single vision spectacle lenses to a progressing myope, except in a very special condition where maybe they're always taking them off to read or whatever the case is, that might be something that's considered negligent in future. And that's a big call, but if this kid progresses and then they get a retinal detachment and you haven't implemented or had some discussion about myopia control, this is something that could be a risk in future. So we know that spectacles have some effects for myopia control, but it really has to be specific binocular vision disorders, which we'll go through in a bit, ESO and accommodative lag, or specific lens designs with particular populations. Soft contact lenses, bifocal and multifocal lenses show some effects, and there's more research, and soft contact lenses are really, I think, where the future of myopia control are going to be, because they're just going to be so much more accessible to all of us, regardless of our mode of practice. And Ortho K shows some very impressive results. This 100% is a shorter term study. So you tend to see big results over the first 6 or 12 months of a myopia control study, and then it tends to wane a bit, and we could talk about why that is for a while. But you can see that the really big goals are to be kicked with contact lens correction, and then there are opportunities for spectacle lens correction as well. So this is in your presentation, and I'll just explain to you, the bars are sort of the percentage efficacy reduction in axial elongation. But the 0.01% atropine seems to have a lower side effect profile, and it seems to have, when it's looked at meta-analyses, a control of 50 to 60%. So low dose atropine sounds very appealing because it's a drop, and say ophthalmologists who are interested in myopia control will be keen to do that because it's a drug. But parents can get confused about the fact that they actually still need a correction. You still need to correct them with something. So it's generally our approach that we'll try and do an optical correction first. Ortho K or contact lenses or glasses, and this is something that we can add in. So some still have very severe progression even with low dose atropine, so it's not the panacea. Atropine concentration and rebounds, I just want to quickly explain this one to you. So the ATOM-1 study, which was done 10 years ago, had a look at, this is the amount, this is an eyeball growing really long, the amount of progression in the placebo over 2 years versus those on 1% atropine. So you can see it's an oppressive myopia control effect. But there's a rebound effect, we know that's an issue. So the ATOM-2 study, which was done about 5 years ago, showed that in the first 2-year phase, the low dose atropine seemed to have the most progression. So that tends to indicate to you that the higher the dosage, the better the effect's going to be, right? If we just have a look at it there. But then what they did in the ATOM-2 study of 5 years, which was published about a year ago, is they stopped them all for a year, and then they had a look at how many of them progressed by 0.50 or more in that year of cessation. And they found that in fact, there was a lower amount of them who had progressed by 0.50 or more in that year. So then what they did at the 3-year mark is they started them all on 0.01% atropine. And they found that over that whole period of time, over that whole entire 5 years, the kids who'd been on low-dose atropine the whole entire time had the lower amount of progression. So you might look at this first of all and go, start on high and then drop down to low, but that's not what the evidence indicates. The evidence indicates that low-dose atropine over that long period of time is actually the one that shows a lower progression over that whole study. Now, this doesn't have a control group, so we don't actually know exactly what the full amount of myopia control is, but it's something like 50-ish%, 50 to 60%. I've just put these in because these meta-analyses of Ortho K efficacy are open access, and then this one you can get because you're students, so they're two really, really good papers which are looking at the efficacy of all of these. And this paper here and a couple of other ones are sort of talking about myopia control in terms of low, medium and high efficacy rather than percentage, because percentage is something that can be swayed by the control group and by the length of the study and all sorts of stuff. And it's something that makes sense to us, but it won't always make sense to a parent. So this gives us a bit of an idea of how these things work in comparison to each other. So bifocal and multifocal, yeah, Suzanne, yeah.
So just in the case of, like you're saying, atropine has such a big rebound, but what about if you just made them take it to like they were 18 or something like that, where we're sort of saying like adult, they're progressing less?
Yeah.
Would that not get around the whole?
Well, that's a great question, and there are so many unanswered questions when it comes to myopia control. I guess the question with atropine is what's the long-term effect of something that could be systemically active on a person, and when we have to put a correction in place anyway, are we better to just do the correction first rather than then having to use a pharmacological treatment? So yeah, absolutely, that could be the issue, but the rebound effect isn't entirely understood because there seems to be a bit of a mismatch between how much axial elongation is changing and how much a refraction is changing in atropine studies. So yeah, could be. And that might be an option for someone who's never going to be a contact lens wearer, to just pop them on atropine. But we don't know when people stop progressing either. That's an interesting point. It can vary for each individual. So for bifocal and multifocal soft lenses, these are the duration of the studies. This is all here in your notes. But the ones that are sticking out here is fitting bifocal soft contact lenses to ESOs. So ESO's definitely got something to do with myopia progression. It's a 1-year study. And then a lens that's probably going to come out from Johnson & Johnson perhaps in the near future is one employing positive spherical aberration to change depth of focus and to change how the accommodation system works. And over a short study, that's shown an impressive result as well. So we're going to hear more about this in future. Ortho K, there's lots of different studies that go for different durations. This is a shorter study, and it was a novel design, which is why it shows a good result. This one here, I wanted to point out it's partial correction. So some people can't get a full correction with Ortho K because their cornea is flat or their script is too high. But this study looked at people who are 575 or greater, kids who are 575 or greater, and just corrected them to -4. And they just wore single vision specs over the top. And they found a very impressive myopia control effect. So it's an option and one that we employ sometimes in practice. And these two are meta-analyses of the other studies, those papers I gave you as a reference earlier. Okay, so that was a little bit quick because you've got it all there in front of you, but we want to talk about putting this science into practice. I don't just want to do a lit review for you. So in putting science into practice, myopia management means identifying risk factors, it means prescribing corrections, and it means providing information and advice. We'll go through each of these in turn. Now this applies to the at-risk emmetrope, and I think this is the perfect picture of the at-risk emmetrope. So her mum's clearly myopic because the specs are off for the computer. We've got a very near-centric environment, and research has shown that kids of myopic parents tend to spend less time outside, so they create a little bit of a myopogenic environment, and this is, I think, just the perfect description of child mimicking parent and that sort of thing changing over time. So the at-risk emmetrope we'll talk about a little bit later on. And the myope, obviously any young myope is at risk of progression. They might not. Sometimes you see here kids who don't progress and it's weird. But we have to assume they're likely all going to progress, especially if we just leave them in a single vision correction. So when we identify risk factors, we've got genetic, environmental risk factors, and then we've got the individual's characteristics. We can't do anything about their family, can't pick your parents, but we can do something about their environmental risks and also modifying their individual characteristics, that being their current refraction and their binocular vision. So we know that when you've got one parent, that increases your risk of developing myopia. When you've got two myopic parents, that increases your risk even more so. And children with myopic parents are at more risk of higher progression, higher levels of myopia as well. We know that children who spend less time outside and more time looking up close are at increased risk of becoming myopic or progression of myopia. And we also know, so we have an opportunity to educate about that and to modify that. And when it comes to the individual's characteristics, the current refraction is important, and that'll be our next slide. If I summarize all of the myopia control studies that have been done to try and give you an idea about the different modalities that have been investigated, it ultimately comes down to central optics and peripheral optics. So central optics is aberrations and binocular vision, which we'll touch on, and peripheral optics is peripheral refraction. I'm sure you've probably all heard about that, and that's sort of the vogue thing that we're modifying with Ortho K and modifying with soft lenses is change in peripheral refraction. But in fact, there's a lot of research to show that myopes have dodgy binocular vision and particular types of dodgy binocular vision, and they have a particular type of aberration profile. And so there's things we can modify, progressive lenses that can modify this, or new contact lenses that can modify this, that are showing results for myopia control as well. So by no means is it a done deal that peripheral refraction is the be-all and end-all of myopogenesis and also myopia progression. We can modify these things with different optical corrections. So current refraction, I want to tell you a bit about the pre-myope. The pre-myope is less plus than they should be. So if you are plus 050 at age 6, that's a pre-myope. So there's no guarantee that they'll become a myope, but they're the ones you need to watch, especially if they've got a family history and we've got these environmental risk factors. There was a huge big study done by Don Moody and colleagues where they had a look at kids for 5 years before and after onset of myopia. And they found, so these are the kids who didn't become myopic and these are the kids who became myopic. And they found that the kids who became myopic, the steepest part of the slope there was that year just before they became myopic. So the kid who changes from plus 125 to plus 025 in a year, that's not good news. And you might think, oh, they're plus, their vision's fine, that's no worries. But they're the kids that you need to watch for. So the risk of high myopia is greater with the early age of onset. So a -2 13-year-old shouldn't worry you as much as a -2 8-year-old, like Sarah and Abby were earlier. And undercorrection promotes myopia progression. So this is something that's important as well, as you're thinking, how much does it matter to this kid if they're undercorrected? We know that undercorrection, which is still unfortunately employed in countries around the world as a myopia treatment, to around sort of the 6'9", 6'12 level, or plus 0.75 is something that can speed up progression. Now, the myopia profile is a profile of this risk factor for development of progression. So we know that when we have a look at the profile, and I've put a lot of clinical resources for you at the end of the presentation, that we've got genetic factors we need to look at, we've got these environmental factors, and then we have to look at the individual's characteristics. Their current refraction, we don't have any clinical way to measure, we can measure binocular vision, but we don't have any clinical way to measure these two. But there are things that we can employ to modify that. So we identify these risk factors first of all, and at the end we'll talk about a communication tool to help you discuss this with parents. And then we need to prescribe corrections. Now, as I said before, don't delay. Start something now, have the conversation now, even if you're already running late. It's a really important thing to do for this patient, just as you would for risk of glaucoma or risk of retinal detachment. We need to think about what we can do for the at-risk emmetrope. And right now we probably can't really put contact lenses on a non-myopic kid because of their risk of becoming myopic. Maybe we're doing that in future. Maybe there'll be studies looking at pre-myopes and atropine use for them. You might think, you know, you've got a kid who's plus 0.25, who's 6, with 2 myopic parents, who spends all their time in their iPad. That might be the sort of kid where we're thinking we want to do something to try and prevent a problem. And if I use the glaucoma analogy again, we don't necessarily want to wait for someone to have a loss of their peripheral vision before we treat them for glaucoma. We don't want to wait for that damage and then to say, okay, now you've properly got glaucoma. A lot of the time our glaucoma treatment is like an insurance policy. We say there's too many risk factors. We've got this, we've got family history, we've got, you know, myopia, we've got high IOPs. We can't be sure what's going to happen to that person over the long time, but we institute treatment. And that's the same thing as you having a conversation about myopia control. So the myope, we've got spec and contact lens options. And atropine, we don't entirely understand the mechanism of atropine. So to your question, Suzanne, maybe we'll be using atropine in these, maybe we're using it on everyone in future. You know, if it proves to be safe systemically, maybe we'll be using it on the pre-myopes. I think we'll find out with time. But when we talk about the changes to central defocus and peripheral defocus, we've got contact lenses that can modify peripheral optics, and we've got contact lenses that can modify aberrations, and then we've got spectacles and contact lenses that can modify binocular vision. So contact lenses are really where it's at. Atropine is obviously our adjunct, and it might be that you do this as a first choice for somebody who's not a contact lens wearer, but it's important the parent understands that it doesn't magically make the myopia go away, because we've had parents go, oh, he still has to wear contacts? Yeah, it's a treatment. So this might be where you start. So, to summarise, loads and loads of research on this. If we want to try and modify peripheral optics, we really need to do that with contact lenses. This is just saying why contact lenses are an important part of myopia control. It's very hard to do with spectacles. DA has done these incredibly complex studies with, I don't know if you've ever read one of his papers, but there's so many equations everywhere you can't really read them, where he's modelled what happens with peripheral optics in spectacles. And when I was at uni, he was walking around in these base 16 glasses, investigating all this amazing stuff about peripheral refraction. He's worldwide famous for his work in this respect. But it's very hard, DA papers have concluded it's very hard to consistently modify peripheral optics with spectacles. And that makes sense, doesn't it? Because the eyeball's moving everywhere in the lens. It's very hard to modify aberrations with spectacle lenses as well. Again, because it's not a consistent thing. It doesn't move with the eye like a contact lens does. Spectacles are probably easier for us to modify binocular vision. And ESO and accommodative lag are our particular enemies when it comes to myopia progression and myopia development as well. But there are contact lenses that can do that as well. So I'll go a little bit more into that. Now, as I said, the mechanism of atropine isn't quite yet understood as it fits into these particular, I guess, methodologies, these things that have been investigated. So providing information and advice. The 3 pillars of really talking to parents about this is environment, so it's important to have a conversation there. To talk about contact lenses, even if they're not interested, to say, all right, well, we'll put you in glasses now, but if you start to progress, we're going to need to have another conversation about contact lenses. Atropine might be something that's mentioned, and then looking at binocular vision as well, prescribing your correction and managing that. Because if you don't, if this kid's still got a huge ESO and a lag, even after you fit contact lenses, you won't get the results you want. We need to manage that as well. So the key message really in terms of environment is the outdoor time. And I don't know how many times I talk about this per day. And I think this is all really quite well understood. But parents are looking for some advice on this. They're looking for some help to tell their kid to get off the iPad, to try and manage this. And so this is a really key message. And the Morgan and Rose study, which was done in 2008, which had a look at the interaction between time spent outside and time spent looking up close, found that even if a kid was very bookwormy, even if they had really long periods of time spent up close, if they spent enough time outside, that the outside time could be more protective than the near work was detrimental. So that's a good news story for parents. Now, we don't know yet what the effect is of a digital device compared to a book, because in 2008, every kid didn't have an iPad and a phone and, 16 different devices. So we don't quite know the effect of that, but that's an important good news message for parents, that if they can work this into the equation, that's very protective against the sort of environment where kids are getting iPads at school in, grade 1 or grade 2 now. So contact lenses, it's an important conversation you need to have when you're doing myopia control in practice, and you need to be comfortable with pediatric contact lens fitting. So seek out those educational opportunities if that's something that you feel like you need more confidence in. We can prescribe spectacles, progressive or bifocal, if the child is not suitable for contact lenses. A little bit later on I'll talk about some clinical resources I mentioned before, but something that I'm not sure if you guys are a member of yet, I know that Angela has shared it in your Facebook group, is a Facebook group called Myopia Profile. Is anyone a member of that? Thanks, guys. If anyone's not a member, join up and I'll add you later, because there's some amazing conversations that are happening there with colleagues right around the world. A lot of them from Australia, a lot from America and the UK and Canada as well, where they're talking about things like, here's a case, should I prescribe glasses? Those sorts of things where you sort of think progressive glasses don't show many effects overall, but they do when employed for these specific binocular vision problems. Some really useful stuff you'll learn in there. The other really useful one, hopefully you're all a member of as well as Sicko optometry cases. I always learn stuff when I look at that. Is anyone not a member of Sicko? You should join up, it's good. Okay, there's lots of retinal pictures and stuff, but if you want to talk about myopia, come to Myopia Profile. So consider adding low-dose atropine if the optical correction doesn't provide sufficient myopia control. The other thing that's very important is to prepare parents. If a child has any myopia progression and they think you've done a lousy job, then we haven't adequately prepared them, because it's normal for a kid to progress. We can't guarantee anything that has 100% efficacy. So we do want to explain to them that this is about the normal amount that's going to happen for your age, and we're shooting for this, to make them feel good that, okay, it's not a fail as soon as there's any progression. And binocular vision is important because we know from lots of research that managing E-Sephora and accommodative lag may provide additional benefit for myopia control. And some of these contact lenses may do this for you. I've just yesterday handed in my PhD thesis on Ortho K and binocular vision, glorious moment, and found that Ortho K does help to beneficially modify binocular vision. And I've got some posters here. I've presented some research posters this year, and I had some extra printouts of that I can give you guys a bit later on for some bonus reading, and I can give the links to Ange to share as well. So we know that contact lenses are where it's at, but then we can use spectacles. You can do good myopia control practice with glasses. And we really need to have a look at binocular vision to pick our targets here. So if we apply progressives to all myopes, we get a pretty low myopia control effect. It's not very exciting, and the message might be that you've heard before, that there's really no point to it. But when we apply it to children with ESO and accommodative lag, we're getting results that start to end up somewhere close to some of the multifocal contact lenses. And bifocal lenses, this is a particular study that looked at, it's the methodology and the type of lens they use, I think, that led to these particular results. And in Myopia Profile, there's been some really interesting discussions about progressives versus bifocals. But look, we've got some results here in the research that show that you can do just as good a job, perhaps, for kids who aren't going to wear contact lenses, or if you're not fitting them at this stage, by judicious use of progressives or bifocal lenses. E-Sephora and accommodative lag are our red flags there. And I could talk about BV all day, but I won't, because we're just talking about myopia right now. But just to talk about contact lenses and binocular vision. So we know that Ortho K does reduce accommodative lag. Other people have shown that, not just me, but my researchers found that, and I looked at it in children and young adults. It does increase accommodative amplitude as well, and it's creating depth of focus. Think about Ortho K like a distance-centered multifocal. So it's going to do something to give the patient an add because of that peripheral steepening we have. Ortho K could also reduce near esophoria. That's something that I found, just a small exophoric shift when compared to just single vision contact lens wear. And there's also been research to show that multifocal contact lenses do reduce accommodative lag, but not by the whole add power. So if it's a 150 add in a pair of spectacles, that reduces the lag by 150. But if it's a 150 add in contact lenses, it might reduce the add by about the lag by about plus 0.75 on average. So about half of the add power. And you've probably experienced that if you fit presbyopes with multifocals, that they don't necessarily get the full add that you get on the label. It depends on the person and how their brain's using the lens. So when it comes to management considerations, you need to ask yourself these three things. First of all, is an at-risk emmetropic child or a myopic child? That's pretty easy to answer, whether they're myopic or not, but it's the at-risk emmetropes that I really challenge you to think about and look at as well. Is binocular vision normal or abnormal? BV is a huge, big topic. You might be a BV person, you might not. But ultimately it's the ESO and the lag, and there's simple ways that you can measure that you need to watch for when you're doing myopia control. And is the child a possible contact lens wearer? Because then it makes for an easy decision about where you're heading in terms of, okay, it's just spectacles, or whether we're going to talk about contact lenses. So if they're an emmetropic child, we need to have a look firstly, is BV normal or abnormal? If their BV is normal and they're an at-risk emmetrope, what you're probably going to do is just talk to them about visual environment. But if we've got an at-risk emmetrope who is ESO with an accommodative lag, we know that these kids with esophoria, with lags, with high ACA ratios are at higher risk of becoming myopes. So you can manage that. That's pretty easy to manage. That's progressives, isn't it? That's a near ad that tends to manage those conditions. Talk to the parents and review every 6 to 12 months. If they're a myopic child, we have a look at whether they have normal or abnormal BV. And then we need to ask at the same time, are they interested in wearing contact lenses? If they are interested in wearing contact lenses and their BV is normal, then just go straight for something like Ortho K or multifocal soft lenses. We've all got availability to those right now, distance-centered multifocals, just the Cooper Vision or the Biofinity ones, Biofinity or ProClear. And if they're not interested in contact lens wear and their BV is normal, even using progressives then is still going to be better than single vision distance. But I have prescribed single vision distance sometimes. And that might be, say for example, a kid's popped into my head who's homeschooled and he does all of his work all day on a laptop, so he's not going to wear his minus 150 on the laptop. And so I know he's not looking through this minus at near, and he knows when to wear his glasses and we're watching him very carefully. There might be those sorts of situations. Last week I saw a 17-year-old who's not progressed in 2.5 years. She's got 2 myopic parents, they're both about -8, and she's about -4, and she's not progressed in 2.5 years. Isn't that weird? That's weird, but sometimes it does happen. And so I did a little poll in the Myopia Profile Facebook group about what would you do in this case when BV's perfect and we've had no progression. Would you prescribe her with single vision, or would you prescribe her progressives? And the overwhelming majority of our colleagues said that they'd prescribe her single vision distance. So there's times where it's a judicious thing to do, but I think you really have to have normal BV, and you have to probably have an older child to do that, or special situations like that. And you warn them that you're not reading in these glasses or it's going to make things worse. Now, if they've got abnormal BV, and again, a huge big topic, by abnormal BV I mean ESO and lag. Progressives might be best. If they've got a whacking grade ESO, you might not get good enough control with a contact lens correction. Or you might go for contact lenses and then give them single vision near or extended focus over the top if need be to normalise their BV. But if you've gone to all of this effort and done a beautiful multifocal soft lens fit or a beautiful Ortho K fit, and they've still got a huge ESO and a huge lag, your work's going to be in vain to some degree. There's still going to be some progression. Now, just to quickly touch on BV, I've had kids come in for Ortho K, referred in for Ortho K with huge big exos. And you probably already know that when you go from spectacles to contact lens correction, that you become more exophoric. And there's some lectures I'll tell you about later you can download from my website that go a bit more into specs and contact lenses and BV if that's what you're into. So these kids, I'm not going to fit them with Ortho K until we get that BV under control, because if an eye is intermittently exotropic, it's just going to progress and progress and progress. Doesn't matter what I fit it to. So in that case, the BV is far more important to myopia control than the actual type of contact lens correction. Now, safety. We know that the riskiest way to wear contact lenses is extended wear, and both soft and silicone hydrogel have a pretty decent risk, even though we think, oh, that's bad, why would you sleep in a hydrogel? It's actually, silicone hydrogels haven't really fixed this microbial keratitis problem. What I wanted to show you is that the risk of microbial keratitis in Ortho K wearing kids, despite it being an overnight modality, is pretty similar to daily wear silicone hydrogel reusable lenses. And there's a new paper, which I think is the next slide, looking at safety of soft lenses in children. And it's open access. It's interestingly found that in kids 8 to 12 years of age, it might even be safer for them than adults to wear contacts because they actually listen to us. They actually do what they're meant to do. They actually wash their hands and do the right things with their cases. So we're worried about fitting kids with contact lenses, but we know that after 10 years of wear, there's no difference in adverse events and outcomes in contact lens wearers who are fitted as teens or fitted as adults. So it's not like there's a certain amount of contact lens wearing years your eyeballs are allowed and you don't want to use them all up too fast. That's not the case at all. We know that there's risk of things like, so CLPC is the most common complication you're going to see in contact lens practice. So we know that that does occur, and we know that infiltrative keratitis can occur, but pretty low levels with daily wear silicone hydrogel. And that's essentially the kid that you might fit with a distance-centered multifocal. By comparison with Ortho K, there's this risk of MK, there's pretty low risk of infiltrative keratitis, but these are both huge, big, long case studies. This one's over 480 patient wearing years, and that one's 1,400, and again showed no vision loss. So these things can be well managed. It's important to reinforce instructions with kids. So kids 8 to 12 years of age need a little bit more reinforcement. So every time you get them back, get them to describe what they're doing with their lenses and how they're cleaning them and in what order and that sort of thing, because kids, as compared to teens, can sometimes lose a little bit in the upstairs about how they're actually meant to do it and substitute very interesting things that you never told them in the first place. So safety of soft lenses in children, you've got this here, and this is an open access paper. So this is a really interesting read to make you more confident about fitting kids with contact lenses, particularly soft lenses. And as I said before, this is really going to be the future of myopia control because soft lenses are so accessible. So make sure you get yourself comfortable and resourced up to be able to talk about pediatric contact lens fitting with patients and their parents. Now, if we have a look at Ortho K versus multifocal soft lenses, there's pros and cons for each. So Ortho K is usually a little bit easier for toric corrections where there's only one type of toric multifocal available. Have you guys heard of the Cooper Vision ProClear toric multifocal? It takes 3 or 4 weeks to come from England. It's brought over by carrier pigeon, perhaps. I can't confirm the carrier pigeon thing. It just takes a while. So, that's not an easy thing for us to fit. Most of these multifocal options are spherical, and the MySight is spherical. So if you've got a kid with a 2D seal, you can't necessarily use a MySight. You're going to have myopic astigmates, and that's where Ortho K tends to win. Ortho K can have limitations in what levels of myopia we can treat, whereas it's easier with multifocal lenses. Doesn't matter what the shape of the cornea is. We might be getting better acuity with Ortho K compared to multifocals just because our treatment zone is bigger. If we've got flatter corneas or Asian eyelids can be the bane of Ortho K fitting because they're so powerful, of any RGP fitting because they can just shove a contact lens around. So that's not an issue with soft lenses. So the safety might be sort of similar. The soft lenses are safer if they're a daily disposable, but it's just to sort of show you that there's pros and cons of each. And if you've got the opportunity to fit both, that you might have identical patients for whom Ortho K is better for one and soft lenses for another one. Now, when we think about peripheral ads, there's a little bit of talk out there about how when you're fitting a low myope with Ortho K, if you're a -1, that you're going to get more peripheral plus with a multifocal soft lens. I don't know if you've heard anything like that. But essentially how Ortho K works is we get this peripheral myopic shift, which is equivalent to the central amount of flattening. So if you try and imagine it like a distance-centered multifocal, a -2 treatment is a -2 correction in the middle with a +2 add on the side. So it's essentially like a +2 distance-centered multifocal with an add of 2, or a 3 distance-centered multifocal with an add of 350. Whereas with multifocal soft lenses, we don't necessarily get that whole amount of add on the front of the lens translate through to relative peripheral refraction. So that add might come through as actual +2 or +150 or nothing. But there's no doubt that a multifocal soft lens is better than a single vision lens. It's going to do better stuff for that peripheral refraction if that's the thing that causes myopia progression in that person. And that's where there's still some question. Now, spherical aberration, you're going, man, hang on, aberration, it's getting pretty late at night. But I just want to explain a little bit about it because it doesn't have to be hard. Spherical aberration isn't a bad thing, and sometimes we're sort of taught, particularly with contact lens designs that are designed to neutralize aberrations, that they're bad things. But spherical aberration is a good thing that gives you depth of focus. And if you don't have spherical aberration, your acuity degrades more quickly in different conditions. So I want you to think about positive spherical aberration like a distance-centered multifocal. So positive SA is where these peripheral rays are focused more myopically than the central rays. This is an on-axis effect, whereas when we think of relative peripheral refraction, that's a peripheral thing, an off-axis effect. So this is like a distance-centered multifocal or Ortho K, and research has shown that positive spherical aberration reduces accommodative demand. So this is why J&J are looking right now at a soft contact lens that has positive spherical aberration in it that's shown results for myopia control, which tends to indicate that it's probably something to do with accommodation. And this is why binocular vision is an important part of this story. This is a non-aberrated system. I couldn't find a Google image of negative spherical aberration, but negative spherical aberration, think of it like a near-centered multifocal. So those central rays are focused more myopically, but near-centered multifocal, then what happens in the periphery. And when we accommodate, our negative spherical aberration increases. And DA is actually very highly published on all of these. Good old DA. So, multifocal soft lenses. What about center near designs? Because you're thinking, wow, we've only got 2 center distance and we don't have any daily disposable center distance lenses right now. So if I want to fit a kid with a multifocal, could I just use a center near design? We know that we have these hydrogel and silicone hydrogel center distance lenses, but we've got lots of center nears. So center distance designs have been investigated for myopia control. These are lenses that were designed for presbyopes, not specifically for kids. We're getting some more kids-specific lenses which will come in the near future. It's an exciting time for you guys to be involved in this level of practice, which didn't really exist probably 5-10 years ago. The center near designs, there's more of them available and in daily disposable, but could we use these for myopia control? We don't quite know yet. So we know that when it comes to fitting a multifocal soft lens and we're trying to make it equivalent to Ortho K, we should try and give the similar sort of ad in a multifocal. But I'll show you a resource later where you can read from a great in this sort of research area about the advice that he gives for fitting distance-centered multifocals. It could be that we could do the near-centered multifocals for problems like ESA4 and accommodative lag. But there's no studies published on this. This is creating negative spherical aberration, not positive. And we don't know what's happening in the periphery. So it may not actually provide the ideal optics for myopia control. So if you're hearing things at conferences about using near-centered multifocals for myopia control, just question that, because we don't have anything in the peer-reviewed literature looking at what might happen over time. Distance-centered, we know that works. There's publications on that. So here's what you should look at. So I've got a website, myopiaprofile.com, where we've just started building some guest blogs. And Jeff Walleen is a very noted researcher he was the first one to publish about soft contact lens myopia control with the distance-centered multifocal. And he's written a blog talking about how to fit these lenses. Over in America they tend to call them bifocal lenses. And he talks about starting with a 250 ad. There was a poster I saw at Arvo in May this year that found that most of the time these kids need a little bit more minus in their prescription to see clearly. And you might think, oh, I can't over minus, that's against my religion. That's what I've been told my whole optometry student life, that I can't over minus. But when there's so much spread of focus in this lens, you might need to actually give them a little bit more minus. And this is what was found was needed in these myopia control studies to give the kids good acuity. So put the new distance power on, try and stick with a 250 ad, and then lower the ad power 1 step if you need to, because we know they're not going to get that full plus 250 on their peripheral retina or for their ad, for their near accommodation. So we want to try and push as much plus as they will tolerate using our best information at the time. Now you might be aware that the ProClear distance-centered multifocal comes in higher ads, so you can get it in a 3, 350 and a 4 ad. But there's been research done on tolerance of how well kids tolerated those high ads, and they're not tolerated very well. Okay, so just some clinical tips for soft contact lens myopia control, because this is the thing that's more accessible for you right now. Ortho K is very accessible for you in the clinic, but it may not necessarily be next year. So we know from presbyopic studies that adaptation takes about 3 days. So don't muck around too much. Give the patient a chance to adapt to the lenses. And it's acceptable to increase at 0.25 or even more, as you would for adults. You wouldn't have any problems correcting so say an adult is +1 with a 2-ad and you fit them with multifocals, you wouldn't have any problems making them +0.75 with a 2-ad to optimize the distance vision. Think about it the same way. You might need more minus and you're not going against your religion to do it. Acuity may be a poor predictor of real-world performance. I'm sure you've heard the term 20 happy. So if you have the presbyopic multifocal wearer who comes back and says, yeah, this is great, and they're 6.6 minus and they're N5 and you're thinking that's not great, well, that's okay, they're 20 happy, that's, you know, that's good enough. Similarly with kids, remember that 6.9 to 6.12 can promote myopia progression, but if we're 6.6 minus, even if we're 6.75, that might actually be an acceptable result for that child. So remember that 6.12 can promote myopia progression, but we should be able to get pretty decent acuity with these. Higher ads are not very well tolerated in kids, so start with the 250 ad first and drop it if you need to. And then the question is, okay, well, if we're trying to make a multifocal soft lens like Ortho K, should we actually fit the ad equivalent to the level of myopia? But because we know the soft multifocal doesn't work exactly the same as Ortho K, you're better to try and plus as much as you can. So it's important to also look at monocular acuity and retinoscopy, and these are tips for presbyopic multifocal fitting as well. You can have someone who is the same script in each eye and they fit with the same multifocal and one eye sees better than the other for distance. So have a look at your ret between the eyes. Have a look at acuity between the eyes, because it might be that one eye needs a little bit more of a tune-up than the other for best binocular outcome. So you can adjust those monocular powers if your ret and VA indicates an imbalance. Now, the ideal myopia control contact lens, this is a paper this is Paul's and my first joint paper, very exciting nerdy times in our household. It was published last year, and this looked at a bit of a literature review of what's out there for myopia control and what the ideal myopia control contact lens might be like. And putting all of this stuff together, the ideal contact lens, which doesn't exist yet, has a beneficial change in spherical aberration. We don't know what that is yet, but it's probably something to do with more positive spherical aberration to support accommodation. An increase in relative peripheral myopia, because this seems to play some role in slowing down myopia progression. Controlled release of atropine. We're dreaming big here. We're thinking of the ideal contact lens. Reduction of isophoric accommodative lag. We know that's a factor as well. And we threw in there real-time feedback on biometrics in visual environment. So imagine if this lens went cloudy after they'd spent too much time on their iPad and it didn't uncloud until they went outside. How cool would that be? Or they get a little flash, beep, beep, you're running out of iPad time, go outside, charge up. So that's our magical lens that might be available in the future, but we actually have a look at the patent literature in this paper. What people are patenting gives us an idea of where the technology might go in future. And no one's doing the virtual reality. Well, there's virtual reality contact lens stuff happening, isn't there? But maybe not that whole making a kid's vision cloud over until they go outside thing. But these sorts of things are definitely underway, and we know that this is a factor in myopia development and progression as well. Or myopia progression for a contact lens, for fitting that to a myope. But specs are sometimes better than contact lenses. So you're not doing anything wrong if you're not going straight to contact lenses, particularly in these cases where prism corrections might be needed for severe BV issues. As I talked about before, those exo kids, Ortho K isn't going to work for an eye that's exotropic. It's just going to go and go and go because of form deprivation. So we need to manage those sorts of problems. Consistent full-strength ads for ESO and accommodative lags are easily achieved in specs. So we know we can achieve some sort of reduction in lag with multifocal contacts and with Ortho K, but it's not as easy and it's not as strong as what you're going to get out of an actual ad in a pair of specs. Bifocal soft lenses, as I mentioned before, reduce lag by about half of the ad power. So it's going to do something. But if it's a monster lag or a monster ESO, you might need more help than contact lenses. Ortho K also reduces accommodative lag and increases amplitude. So remember these ones. I know I've said that loads of time, but I just want to hammer that home. Isophora and accommodative lag are the things that we really need to monitor when we're doing myopia control in practice. So if BV is normal, go for your contact lens options. If they've got a massive ESO, we know that the Ortho K and the multifocals will do something for that. It might not do the whole job, and so you might need some extra specs over the top. But if someone really wants to be a contact lens wearer and they're happy to still have those specs on in the classroom, that could work. But if they've got a huge big exo, like those couple of cases I've mentioned before, specs might be better to get that under control before they go to contact lens wear. Now, I've got a website, kategifford.com.au, where I've got a lot of lectures up there, and you can download any of them as PDF and have a flick through them. So there's a couple of here, contact lenses and binocular vision, which talk a bit. I mentioned earlier that when you go from specs to contact lenses with a myop, you get exo. The opposite happens for a hyperope, they go ESO. So these sorts of things are important to think about for any contact lens practice. But the thing I'd really urge you to remember is if you're not really a BV person, is anyone not really a BV person in here? Yeah, so not really a BV, Paul's not really a BV person. Okay, what I want to tell you is most of your patients are going to have two eyes. Sometimes they have one, never do they have three, but most of the time they have two, and it just gives you so much more information about their clinical presentation, so much better for problem solving to have a look at BV. And have a look at this stuff here, and I want to talk about that at our next lecture as well. I want to make it easy for you guys, so if you're not a BV person, that you might come away going, I can do this, and I want to own a prism bar, and then I will feel that I've contributed something to the world. So clinical resources are out there. So have a look at the website myopiaprofile.com. So this shares a clinical resource tool that we use here in the practice that I developed many years ago to try and help me with these long and arduous conversations I was having with parents about environmental risk and BV risk and all this stuff, and they can't take it all in. So you're free to download that and use that as you see fit, and it comes with a little resource kit as well, so it's a practitioner guide explaining the background to it. We're developing this. We've developed a pre-myop version. There's a version in Chinese. There are other translations coming through as well. So have a look at that. But it's also got a blog. I mentioned before Jeff Walline's blog you should have a look at in terms of soft lens prescribing, and some how-to guides as well. So there's some how-to stuff on there about BV, how to measure accommodation and how to prescribe for lags and stuff coming about vergence as well. This website here is another one that I really need to give credit to Paul for developing, along with software engineer friends of ours. And this is for parent-facing information on myopia. So we launched this towards the end of last year, and it went crazy within a week. And we've got lots of colleagues around the world, particularly in America, who are using this as an in-room discussion tool. So they might hand the website to a parent on an iPad or ask them to look it up, and they do a short 5 or 6 question survey about sort of environmental and family risk, and it gives an idea of the child's risk. It's not a risk calculator or anything like that, but it just gives an idea of risk, and it's a very good thing to help parents to get what you're trying to talk about. And that can be shared on Facebook pages and websites of the practices you're working in and that sort of stuff. So feel free to use that as you see fit. And all of the drawings have been done by Paul's daughter, my stepdaughter, who's currently top of art, no big deal. But they're gorgeous, so it's really appealing to parents and to patients as well. Myopiacontrol.org is another fantastic one for us, for clinicians. Publication abstracts and blogs, and they're just starting to do some podcasts as well. Myopiaprevention.org has got some good stuff there for parents to look at as well, so it's a good resource. We want to build more sort of patient-facing resources on My Kids Vision, so we want to eventually be able to have downloads that you can just print off and give to parents about outdoor time or about contact lenses, so we'll work on that stuff in our spare time. Now, also some more things to read about the just putting this into practice is a couple of things that I've written, one for My Vision and one for Contact Lens Spectrum. Contact Lens Spectrum is a professional journal, so it's not a peer-reviewed journal, but it has really good clinical-facing stuff that you can get. You can subscribe to this. It's a US-based journal. But these are just open access, so you can just download these right now. So this is these are both a bit of a literature review and then also talking. It's a good overview of the sort of stuff we've talked about tonight. And then I want to get you to have a look at this one as well by Langus Michaud. And this is defining a strategy for myopia control. And he's got some really good flowcharts that they've worked out at the University of Montreal, their myopia control clinic, around pupil size and Ortho K and various choices between different modality options. It's just a really interesting read. They're all very easy to find if you just Google, go to Google my surname and contact lens spectrum, or Google Michaud and contact lens spectrum, and you'll find that quite easily. So in summary, your myopia control practice, what you're doing in the clinic now, and most importantly what you're going to do when you're unleashed on the big wide world next year, is to determine the intervention and remember to remeasure binocular vision, because that's a really important part of the equation. Don't forget the pre-myope, so we can manage ESO and accommodative lag for them, and we need to provide advice about visual environment. The risk of contact lens complications with these myopia control devices is something we need to be cognizant of, but it's probably less than you think, and the risk of these future pathology is certain. And that's why I spent about half of this talk just really trying to make sure you understand that why. And if you think about that glaucoma sort of analogy, it's the same sort of thing. It's those risks that occur if we don't treat. Contact lens compliance is generally good in kids, but remember the younger kids, so kids versus teens, need reinforcement with care and maintenance. Contact lens safety in children is similar to that in adults, and in fact with younger kids it might even be a little bit safer because they actually listen to us. And you've got that open access paper you can download, or everything's open access for you when you've got a QT login, so do it now while you're still a student. And make sure you provide advice on visual environment. This is really important for the pre-myope, but every myope you'll find yourself having this conversation about outdoor time and how that's important. Use online tools to support your clinical management. I've hopefully given you a whole compendium of stuff there that you can use to make it easier. So there's the websites that you should have a look at, and there's more in the presentation as well. And thank you so much for your attention. Hopefully you've learnt lots of stuff. Thanks very much.